All right. You guys ready? Hi, everyone. Thank you so much for joining, especially those who are staying after the AUS meeting for another hour of exciting ultrasound. We will bring everybody to find a seat inside the room, and then maybe if there's anybody in the back that could close that door on their way in, oh, that'd be perfect. And then we're going to go ahead and get started with our wonderful group of presenters here. My name is Yo-Yo Duanmu. I am the AUS Research Officer, and these are members of our SAMES committee who have been there for at least 2 years, so have seen a lot of really high-quality POCUS research. Some disclosures for CME, and then our introduction. So basically, as part of our SAMES committee, what we do is we go through every AUS member, which this year is just about 600 people. We search for every publication that they've put through, and this year that was about 300. Read them all, and then sort them into 7 categories. And get a really good sense of what is up and coming in the world of point-of-care ultrasound. And so the articles chosen by the members of the committee this year are not necessarily the SAMES winners, but ones that made them think, ones that made them consider this might change the way I practice clinically, or this might be a direction of future research that any of you can take back to your shops and potentially come up with the next big article for 2025. So some of the learning objectives are going to be to summarize key findings from impactful articles from 2024 and to think about how these might be implemented into either practice, research, or these emergent areas that might be things to watch over the next couple of years. So I'm going to go ahead and hand it over to Dr. Gottlieb for our observational study.
Hi all, I'm going to stay over here, number 1, because my phone is really working well, and number 2, I just don't like being here. So the article here, this is by Toronto All Media, and that from the SAMES before. The QR code's up there, the thumbnail is up there. It's also in your show notes, and apps as well. As well. So T. So, who here has T as a job? This is the pretty proper. This is our generally ultrasound oriented population. What we want to know is that how is it being used? So what Toronto and their team had done was this off the studies. So this is a real world setting. We know that resuscitation, which is in the acute setting for cardiac arrest or procedures, we're on stable hypertension. How is that actually doing? It's a hard thing to do. Doing prospective observational registry kind of work is hard. So they built this out, they built a whole team called Collaborative, our team 4 is what they abbreviate as, and they saw the whole registry. And I like this because registry is a good model for one way of trying to see people prospectively. We have all these great sites and how to do things, they extend beyond the sort of called single site research into something broader. So they looked at this as a prospective, multi-center observational registry. They looked at the OR, ED, ICU, and pre-hospital setting. 5 different applications. They looked at in-hospital, out-of-hospital cardiac arrest, undifferentiated shock, hemodynamic monitoring, and procedural applications. And trying to tell us how are we going to actually implement this in practice. Now, I brought this up for 2 reasons. 1, I like the methods. I thought it was good for a lot through those. Number 2, I like to do everyone a shot. I want to talk about that too. But first and foremost, they sent out this central hub model. What they did is they sent out the University of Pennsylvania. They had all sites had to report at least the university say report at least 90% of the T usage. So that shows that we're actually doing T that phantom scanning, at least to the degree that we can control, is being tracked through this for all the information. So minimum 90% reporting. They use standardized tools, they write text to ensure consistent reporting. So if you're going to do a registry, the worst is if you have discordant data at the end. So they were very academic to say, let's make sure we're collecting the same variables. We're training up our people. They had dedicated training sessions. They had refreshing staff, and they were very transparent with the paper. Like 17 pages long, and same footnotes. The version is that they had very step-by-step models, so you could replicate and say, how did they do it? How can I do the same thing? Each side had the de-identified T images, so you can actually see and match up with the reporting what they saw. And they had, again, individual group training with centralized QA to actually set the images later as well. These are the number of variables there, which is pretty impressive. This is not up here for you to read through every single thing because it's on the PDF of the thing. You don't need to read through this. It is to see how much things they were able to capture because they actually trained everyone up. They got really good data. If we have big lengthy forms, we don't train people up, there's a good chance we're going to have really heterogeneous data they can't use. And that's one of the key things again. If you're going to have these registry type models, making sure you're training and retraining and checking the quality of the data. So what they find, they look across 28 different hospitals. 23 EDs, 12 ICUs, 2 ORs, 2 medical floors, 22 academic, 6 communities. Again, one of the arguments that I'm not sure you all hear, I often hear is, well, that's great that you're using T in your tertiary care academic center. What about community setting? So they studied this. They included the community setting to help show us that, yeah, this actually does work in both settings. The median number of T's in the time period was 21. This was relatively early in the registry. I think that number's kind of expanded quite a bit. But it's 21 scans now. We're giving you about a 2-year scan. This is the distribution. I'm just going to kind of highlight out some of the color codes. So the majority were out-of-hospital cardiac arrests, followed by in-hospital cardiac arrest, and then undifferentiated shock, which I think probably ICU more commonly, but we do see some of that in the ED as well. And then you can see across here, hemodynamic monitoring and then procedural guidance in that far corner. So it's actually distributed across more than just the typical cardiac arrest we think of. Because I was, well, at least when I was first building MIT, I was thinking just cardiac arrest, but the ESF guidelines have expanded that out, and as we see in practice, that's expanded out as well. How to change management? That's the other thing. If you're going to do a procedure, what's the value out of this one? 83% of undifferentiated shock get a change in meaningful management. 47% of those would have hemodynamic monitoring, more commonly in the ICU. 71% of in-hospital cardiac arrest, 62% of out-of-hospital cardiac arrest, and a change in management directly resulting from TE usage. And the complication rate, 24%, those are all bleeding, which are pretty minor symptoms. This is the distribution, and if you kind of look at the key things here, is that really it's mostly looking at like things, for example, looking for early PE or pseudo PA, but you can also pick up things like finding fit, which got a lot of attention. That was almost 30% here. You can see a relatively significant number of meaningful changes that are actually changing how we manage our patients. So what we find in conclusion, this was a successful multi-center prospective TE registry. They were able to show us, similar to Dr. Goldman's excellent neuroblock registry, that did some of the same and had value in a real-world uncontrolled setting. But there's limitations. Again, we're focusing on some of the literature, a couple things to be aware of. One is recall bias. If you're doing something after the fact, you might kind of remember things slightly differently, especially if you're a big fan of TE. There's also the risk of reporting bias, and then maybe just that before again, on the principle, we're looking at this, we may say, the TE is not percentage, maybe that'll be probably 10% not reporting. That risk always exists, conscious or unconscious. Self-reporting bias, because they say, I'm going to change, my management based on this, and maybe the management soft change, and you're really good at TE, so you're like, well, I was probably going to do play the check anyway, but now I'm really into the check. Those may be a little bit, again, skewed by some of the self-management parts of it. Confirmation bias, and then you pick up the beat bit monitor, and you say, I was trying to beat bit monitor echo, you've now kind of led to your own confirmation bias. And then just like the differences that you look across OR, ED, ICU, they didn't really break it down as much, but I think they expect more for people to come. So what's the impact? This is something that you can use, one, to see how TE is actually used in the real world. Number two, if you're trying to build a registry, see some best practices, see a good example of how to build a robust registry. And then finally, just to help for your own practice. If you're trying to make an institutional argument, why should I do TE? This gives you a very large-scale study that can show, yeah, across a wide range of sites and locations, TE does impact management as a safe application. Future directions. I anticipate they'll probably break some of this down by your training. Our residents are factor difference, sensitive differences, and again, more work on actual decisions based on teams, or can we now randomize the patients and see if we make
Thank you. Hi, can you guys hear me? Okay. Okay. So I chose this article for interventional studies because I think it's something that we all struggle with, and I really liked this article because it was quite a novel way of thinking about how to overcome some of these struggles. So this study looked at effective departmental and physician selected interventions on point-of-care ultrasound documentation completion. Dr. Jeremy Boyd is here, but it came out of there. So how many of you at your institution institutions struggle with getting non-ultrasound faculty to use ultrasound? How many of you struggle to get non-ultrasound or even ultrasound faculty to complete the workflow? Yeah. So I think this was a great study where they essentially did semi-structured interviews with faculty who were high utilizers of ultrasound and low utilizers of ultrasound. They then implemented an incentive program which looked at shifts. So at this particular institution, they get a select number of shifts they can request off. And so this incentive gave them additional shifts that they could select off for more flexibility with their scheduling. And then the next part of the intervention looked at shifts as well as people. So the primary outcome they looked at was monthly rate of documentation completion. So they looked at all the studies performed as well as those that ultimately were submitted. And then the secondary outcome just looked at the impact of date fail reminders. So the interviewed those high utilizers and the low utilizers. These are some of the things you kind of would expect them to say. So the high utilizers felt like it really impacted their medical decision making, made them better doctors, they were better with procedural guidance. They were ultimately more confident in their ultrasound skills. And so they used it more often. The low utilizers had concerns about billing, maybe double billing if you're not a lot. Liability is always a concern. And then they also weren't as confident in their ultrasound skills and commonly rely on the residents to kind of do the studies. And so that led to them being less likely to complete the ultrasound workflow. And then other barriers we face where maybe the workflow solution's not ingrained into the electronic medical records. You're having to go into a completely separate system. I know I forget this all the time, and like at the end of my shift, I'm like, oh, I need to submit my ultrasounds. There's always difficulties with workflow, whether it's the machine breaking, not connecting to the system, the difficulty opening the app. There's all sorts of issues. And then something that came out of the interviews that was brought up as a potential solution were these daily email reminders to say, hey, you did an ultrasound, you didn't complete the workflow, here's a reminder to complete it, and get with your Epic inbox. So when we look at period 1 here, we see that our baseline use was around, our baseline submitted over performed was 45%. After the first intervention, which was our period 2, you see it spikes up to 60% of exams that were performed ultimately got submitted. And so it went up by 15%, which is a pretty big difference when you added that shift incentive. So they kept the shift incentive for the remainder of the study periods. In period 3, you can see that it's still, there was a drop off, but it ultimately was still 12% higher than baseline. And then they just looked at the sustainability period. So they took away the emails and kept the shift incentive, and were able to see that their submitted scans were higher than their baseline without any intervention. So in conclusion from this study, low utilizers stayed low, and I think that's just what happens, and that you're going to see that probably no matter what intervention you're using. Interestingly, emails did not significantly increase the rate of submission. The shift incentive actually was the biggest impact, which improved submission by 15%. So this is a really interesting topic to me because I think utilization is something that's really important. We spend a lot of time and money and resources training our students and residents and faculty how to use ultrasound. And then when we study if they're using it, a very low percentage of people are actually going on to use it. We know it's better care for our patients, shorter lengths of stays, better for procedures, but like why are people not using it? So there's been some other studies. I know one came out of Mass General, where they also did a implementation in the sciences type study where they looked at barriers and facilitators to ultrasound ultrasound, but I think that that will continue to be a future direction of ultrasound research. Like, how do we get people to use it? Why are they not? And how are we addressing these barriers? That's the first barrier or kind of topic. And then the second one is once they're using it, how do we then get them to actually workflow solution? And so if you're at a place where shifts are regulated pretty heavily, this may be an incentive that you could implement to try to increase your completion of the workflow solution. And then there are probably other solutions out there we may just not know them yet. And so again, another future area of study.
All right, my name's Josh Davis. I'm going to apologize for finding a flight to catch after this, so if you need anything, that's why it's not available to you all. I chose this study for cross-sectional study. Deep learning generated B-line score mirrors clinical progression of disease for patients with heart failure. The reason I chose this study is really in the spirit of this presentation, which is wave leaders. So there are some, like, you get into fine details of the research methodology, there are some issues with this study. However, I really think that this is where the future of ultrasound is going to go, and I really felt this study made waves for me in thinking about kind of envisioning where I see ultrasound coming in the future. It's going to be an important thing to know. This group, I don't really have to spend too much time explaining, why ultrasound is important in patients with shortness of breath and heart failure. But one thing I do want to highlight that you may not know, many of you do, this is one of the few indications that the ACP, the American College of Physicians, has for internal medicine physicians to have is to learn how to do lung ultrasound. I put a picture of a heart up there. Don't ask me why. It's just a choice for heart failure. But then we also have, the ASAP and the SCCM and the other guidelines for kind of using ultrasound for heart failure in terms of accuracy and change in management. The big thing that I want to highlight here is the artificial intelligence, and that's really where I see this study kind of shining in. They use artificial intelligence here to actually develop a score, and that's really where I see the future coming, and that I'm going to get to here in a minute. So what they did, they took 253 patients, many of whom their original plan was just patients presenting to the emergency department. They didn't get to all of those patients. They actually just went to the heart failure floor. Apparently this hospital has a floor for just heart failure patients. So they went to the heart failure floor and also picked patients as well. They picked 253. Eventually, as they got through the study, they only got down to 110. So like I said, there are some methodological issues. They used some for refining their AI process. They'd actually already published their AI process previously. They examined 8 lung fields. If you actually look at the lung fields, they actually didn't do any posterior lung fields. They did lateral and anterior. I don't know if that's because people just didn't want to do it, but you think that posterior lung fields would be pretty easy to get in 4 patients, and probably might have some area of change that you want to look at. However, they did their 8 lung fields. They had to exclude some because there weren't 8 lung fields done. They didn't do more than 6. They excluded them. They also excluded them if they didn't cross over, they didn't finish their workflow, didn't get their shifts changed appropriately. And they compared this to a couple things. They used the Rothman index to look at severity of illness, but the big finding here is they use this composite congestion score. And I put this up here because I figured some of you, myself included, may not be familiar with it. But it covers most of the things you would think of if you would ask someone, and it rates it on a scale of 0 to 3. For 6 different indications, so you can get a score up to 18 or 0, depending on how congested you are. And the big real finding that they had here was that their AI algorithm correlated with this composite congestion score with a coefficient of 0.7. Now again, it's only 100 people. They did have 8 different lung fields, so they got a little bit more video clips on it. They found this kind of slightly large confidence interval, but this coefficient is 0.7. And again, this is a small study, so there is going to be a large confidence interval, but I think this mirrors what my clinical practice is as well, which is that when we find B-lines, that it correlates with people's congestion. And one of the things is they also excluded people who didn't have a final diagnosis of heart failure, so they missed out on a couple of people there. So what I find here is that patients with heart failure, this is additive data that we kind of already know from our ultrasound experiences, is that B-lines correlate with congestion. But what I really found interesting here was the use of AI and how we can revolutionize that in the future, and how we can utilize AI in people who maybe aren't high utilizers of ultrasound. And we already know it doesn't take very much to teach even medical students to do ultrasound, residents and faculty to do a simple ultrasound. Think of how easy it would be in the future if we had an AI that you put the ultrasound probe on, they tell you it's a green light, you got a good image, and it spits out a number for you. Doctors like the numbers that are in the chart, right? And we like the troponin, we like the PMP. what I really see as far as the future direction for this in terms of clinical impact is we can do these ultrasounds even in austere settings or even in academic settings with people who aren't super familiar with ultrasound. You do the ultrasound, it gives you a green light, it spits out a score, and that score ends up in the chart in your lab section as your congestion score, your ultrasound congestion score is a 9, and so that means you have more diagnosis to do. As far as future research, I think really where this needs to go, it needs a larger sample size across a variety of people. We also need to find out where this impacts outcomes. The outcomes I think are going to be really important. However, I think we can predict people who are going to bounce back within 30 days of their heart failure, which we know is one of the main metrics that the hospital cares about. It is a frequent use of emergency departments and hospitalizations as patients with heart failure return. I think if we can use this, diagnostically determine patients who are safe to discharge from the emergency department, and then also we can use this as a tracking when we admit patients to the hospital. We can trend their congestion score and then know when they're safe for discharge. I think those are the kind of the future orientations that we want to see. Is we can use this AI algorithm to help improve clinical care, just like we've seen AI used across multiple other things that are also coming with documentation and triage and all of this. All right.
Hi, everybody. I'm Lynn Ruppel from John Peter Smith Health Network in Fort Worth. I know I'm retired professor for residents. And then go through some fellowship at very old age after being part of the leadership for a long time. So the paper that I picked was actually something that is very practical, something that I think that we're very familiar with. But there has not been kind of studies of specific protocols and their success rate. I really liked their methodology. I thought it was very believable. I thought it was repeatable. I'm an editor, and I just feel like it was a simple enough study that I can share with you, and you might think, oh, this is something we can even workshop and even extrapolate it to other populations and even some comparative studies. So I talked to the first author, Hillary McKinley. Of course, she cannot be here, but a very delightful person. So this is ultrasound guided prophylactic access training, a prospective observational study of emergency nurses. So again, not as much evidence for success rate, which is what prompted their study. So as far as the methods, they picked nurses in the emergency department who had more than 2 years of experience as a patient population, or I should say for subject population, and this was completely voluntary. However, the nice thing is they had motivation. They wanted to get credentialed, and in that particular institution, to get credentialed to do ultrasound IVs, they needed to do 10 of them. So they kind of like piggybacked on the baseline requirement for the hospital and actually studied it and created a nice curriculum, if you will. So here's the curriculum. It was 1 hour of didactics followed by 1 hour of simulation. And they used tofu as their model for needle tracking, which was really cool because we had actually a lab recently, and I was inspired by this study. We used the tofu model, and how many of you have used the tofu model? It's really cool. I mean, when you use the phantom, there's that streaking when you pull the needle out, and I didn't see that. We used it multiple times, and by the time I was like the 6th person that used that jiggle model, we had the second one, and it's super cheap, very transportable and easy to purchase sort of thing. So they use the tofu model just for needle tracking, and we know how complex that is to teach and to learn. And then they actually used live models for what they for human subjects, and I think they used other nurses and themselves. And then after they had this baseline training, the ultrasound faculty took the learner into the emergency department, and they actually observed them doing these ultrasound guided IVs on real patients. And they did identify the people that were at risk, or the risk population that had difficult IVs, and they kind of described that. But what was interesting is they were with the learner the entire time, and they had a checklist of things that they needed to do, but they weren't allowed to touch the probe. So this was all kind of verbally. They did 10 and then +1. And the +1 was when the observer or the instructor didn't say anything at all. So it's kind of like the test, if you will. I mean, they only allowed them to have 2 attempts per patient. So here are the results. It wasn't a big study, but they had 60 people, who completed the training, and then 14 who actually completed the credentialing, a bunch of ultrasound guided IVs, overall success rate, you can see here, 80%. They had 20.8% were difficult IV access, and the success rate on those difficult IV access patients was 68%. What was interesting, and a data point that I think is important to document because I think we justify our time as educators, is that median observation time, and that was not the education where they did the simulation or the didactics, but then actually in the ED, finding patients, getting them machine ready, including all those steps that actually take time. So the median time for all that to get the training for each individual and credential was 4 hours. And then, not surprising, the most common reason for failed insertion was needle tracking. As we can see here, that dynamic ultrasound guidance is kind of challenging to teach. So here is the checklist. No surprises there. These are things that they didn't do inter-rater reliability, but I think just looking at this checklist, it's pretty clear what people were measuring for success sort of thing, and keeping track of their complications. So here, I like, pictures of 1,000 words. These are all their learners, the x-axis, if you will, are the study participants. On the y-axis, it's like in 5 attempt blocks. And then this is kind of the progress of each individual learner. The green means that they had a successful insertion of the IV. The red is a failed attempt. And then the dot in the square means that somebody with difficult IV access. And then at the very bottom, you can see that 11 or that +1 attempt, and all of them were successful except one. And then for, I don't know what reasons, but 2 of them actually didn't do that 11 IV for their test. So in conclusion, there's no prior experience, you get credential, no surprises there, but here's the curriculum. I think they did a good job of demonstrating its effectiveness. Limitations, a small sample size, they didn't follow them long-term, limited details of ultrasound faculty with oversight. I think you can kind of imagine how it looked with their observation and their training. The impact, I think it just demonstrated this effective curriculum. It was very simple. The methodology is I think, very straightforward and something that we can repeat and follow, and just supports this training and requirement for credentialing. However, for future direction, and this is kind of something that I'm passionate about studying right now, is maybe we can make it more individualized and we can do some learning curves on this, so it doesn't take 10 to get to credential, especially for some people have to get it really quickly. And then other thoughts are, do we need ultrasound faculty trainers? Well, we don't. We have a lot of very experienced persons that are better than many of us at doing ultrasound guided IVs. And in our shop, we actually have a lot of techs that are doing that, like paramedic people that are in the ED that are also doing ultrasound guided. So I think that's it.
Hi there. Unlike my brilliant colleagues before me, I'm going to embrace the podium here. Let me know if you can't hear me. My name is Kristen Dwyer. I'm here from Brown, and I'm going to be presenting from the category of systemic review and meta-analysis, this article titled Artificial Intelligence Applications for Point-of-Care Ultrasound in Low-Resource Settings, a Scoping Review. All right. Background. So most of us here probably have drank the POCUS Kool-Aid, but POCUS offers obvious advantages over alternate diagnostic imaging such as CT. It's affordable, it's portable, and it's got no radiation. Arguably, the value proposition of POCUS is even stronger in the resource-limited settings. As POCUS continues to be widely available in austere settings, AI can facilitate with image acquisition and with image interpretation to bridge the gap of medical knowledge and available technology. The aims of the study were 2. The first aim was to examine the current state of POCUS AI for low resource settings, and the second aim was to identify the limitations and barriers that those AI systems face. The authors used Cochrane and Prisma guidelines to enter appropriate keyword searches in these 3 databases, coming up with 1,159 records that entered their screening process after duplicates were reviewed. Of the 1,159 records that were identified, they went through the first stage of screening, which involved reading the title, reading the abstract, and looking at the study type, along with their inclusion and exclusion criteria to see who made it through the second stage of screening. 241 records were identified for the second stage of screening, during which all of the authors reviewed the full text of all of those articles. They then used, again, the inclusion exclusion criteria to decide which of those articles made it to the next step to be included in their review. And when there was disagreement, discussion occurred between the authors and consensus was reached. Ultimately, 29 studies were selected and included in the review. The inclusion and exclusion criteria were, as expected, point-of-care ultrasound, AI, low resource settings, peer-reviewed, and not systematic reviews. In terms of the results, majority of these studies took place between 2021 and 2023, and they were conducted in departments ranging from emergency medicine to ICU to OB to cardiology. Now, I had to write some notes. I tried really hard to memorize these flags, and it was not possible. So countries represented in these studies included in the review included Ethiopia, Canada, Nigeria, Zambia, India, South Korea, Vietnam, Egypt, all right, that's the one I kept forgetting, and Norway. So you would think there was a lot of geographic diversity included in the reviews, but actually almost 70% of the studies took place in the US and in Canada. In terms of the resource limitation, what does that mean? What were they looking at? There were 4 categories of resource limitation that they considered. The largest category by far was limited resource, which was about half of the studies. And they define limited resource by not having adequate trained personnel or computing resources. So for example, if you have neonatal lung ultrasound being performed by people that are not neonatal lung ultrasound specialists, they had some studies where patients were performing scans for COVID on their own. So those kinds of things would be categorized as limited resource versus studies that occurred in rural and remote areas, studies that occurred in low middle income countries, and then the smallest category ended up being sort of emergency or disaster areas. The populations that were covered in these studies included lung ultrasound for pneumothorax, for B-lines, for COVID-19, bladder volume, infant hip for developmental dysplasia, gestational age, including mean abdominal diameter and head circumference, ejection fraction, breast cancer, to name a few. So what were the limitations of the studies that were identified? Well, as expected, the vast majority of these studies are really pilot studies with very limited generalizability. So for example, you take an AI technology that's being trained on developmental dysplasia of the hip in one region, and you can get a well-performing AI technology. If you try to take that technology then and use it on a different ultrasound platform or for a different diagnosis of the hip, or even for a different racial group or area, it performs less well. So really, there's a lot of struggle with the with generalizability of these AI technologies that work quite well in a limited group that they're trained on. Another limitation with these studies is often it's really difficult to get data sets that are robust enough. So you need a really large data set to train these AI systems. As already mentioned, the majority of these studies were not really occurring in low middle income countries. And then standardizing across devices, protocols, algorithms is something else that complicates things. So a system that does very, very well on ultrasound brand X doesn't always translate well to ultrasound brand Y. The AI algorithms that are being used, while they were primarily deep learning, there are multiple other algorithms being used at all. So there's not a lot of standardization across the algorithms. All right, so what is the future landscape of AI in POCUS? If the future AI research can produce technology that performs well, is affordable, is reliable, and is user-friendly, and functions on a wide range of platforms, which I'm hoping can occur, This technology could effectively empower the novice user in the low resource or austere setting to perform POCUS with high fidelity for our patients.
Hello, friends. My name's Sam Lam. I work at the University of Colorado School of Medicine, and I'm trying to be a little bit ambitious here. We're going to talk about not one, but two manuscripts in the case report category. The first one is entitled The Lip Liner Sign Potential Cause of a False Positive Focus Assessment with Sonography and Trauma Examination by Dr. Maria Parker and colleagues, published in the Journal of Emergency Medicine. This is a case series of 4 patients, including 3 trauma patients and 1 healthy control, that shows an artifact that mimics the free fluid on a fast exam. This occurs most prominently on the edges of solid organs, such as the liver and the spleen, and is caused by the machine processing algorithm to reduce what we call speckle artifact, and in order to achieve a better definition of organs at the tissue borders. So paradoxically, in trying to get rid of one artifact, they created another one, which is called the image adaptive filter artifact, or simply the lip liner sign. And as the author has pointed out, it can be seen on multiple machines in different mix and models in the POCUS world. And these are 2 examples of the lip liner sign. The one on the top shows a hypoechoic line underneath the liver, highlighted by the red arrows. The one at the bottom is also a lip liner sign, highlighted by the red arrows at the Morrison's pouch, in addition to a bonus sign, which is the double line sign, which is highlighted by the yellow arrow, which is caused by the perinephric fat. The caveat to the lip liner sign is that it's usually a uniform hypoechoic line, whereas in cases of free fluid that's real, it usually forms a wedge shape, decreasing width as it dissects into the deeper tissue planes. Now, the lip liner sign, or this artifact, has been widely known in the emergency ultrasound world for a little while, but this is the first time that it's given a name, which is the lip liner sign, and kudos to Dr. Parker for doing that. And everybody doing POCUS and FASH should be aware of that because of clinical decision and QA purposes. Just a little bit more self-promotion here. For more details on the physics and how to minimize the lip liner sign, please read the ASAP Ultrasound Section newsletter, the March edition. An article by Dr. Rob Ferry describes in a lot more details for the geeky ultrasound people out there. And we are, on the ASAP side, working with the vendors to try to minimize the lip liner sign on various ultrasound machines. The second article I'm going to talk about, it's Ultrasound Guidance for Real-Time Management of Acute Ischemic Priapism by Dr. Bob Sternberg and colleagues, out of the American Journal of Emergency Medicine. There are procedures that I used to love as a resident but hate as attending, and priapism management is one of them. It occurs so rarely, and there's so many different structures in a very small amount of real estate. So this is a case of a 44-year-old male with painful erection lasting 8 hours. This gentleman has a history of poorly controlled diabetes, but no sickle cell disease. He did use sildenafil 3 days prior to arrival and presented to ED with a painful erection. This is a case where there's a real-time ultrasound guidance in ED treatment of painful priapism. So there are 3 steps to doing this procedure. Step 1 is the penile nerve block. So we want to take a linear probe, cover it with a sterile dressing, and place it transversely over the ventral part of the penis. The reason that you want to do it ventrally is because when you inject, you want to inject dorsally, and just ergonomically, it's a lot easier to put the probe on the ventral side. But this is important because most of the time, when you look at ultrasound, you might want to just do it the other way around. But this probe placement is on the ventral side. So after that, you want to insert your needle dorsolaterally and advance in a plane underneath the buccal fascia, and injects about 5 cc of 1.5% lidocaine. And in the picture below, this is where you should do it. I don't know if you can see the asterisk very well, but the asterisk is usually where the needle should go in. So you should go in between the buccal fascia and the tunica albuginea, and inject where the rest asterisk is. Second step, it's blood aspiration for corpus cavernosum, which is an ultrasound-guided in-plane needle entry into the corpus cavernosum while you're trying to avoid dorsal arteries and the nerves at the same time, in addition to the artery and the corpus cavernosum. What you want to do is want to aspirate approximately 20 cc of blood out of that, and the picture below in the bottom shows you how it's done in real time. Step number 3, injection of phenylephrine. You want to take your phenylephrine, inject about 500 microgram of it into the corpus cavernosum with ultrasound guidance. And once again, the picture in the bottom shows you how to do it in real time. And after the procedure is done, you want to apply compression bandage before sending the patient home. The patient, in this case, follow up at the urology clinic a few weeks later and did well without complications. The reason I picked this article, it's, as I said before, because it's a pretty uncommon procedure, but can be limb saving if performed properly. But it has the potential for blood vessel, nerve, and urethral injury if performed blindly. So this is a first description of a POCUS-guided procedure to treat parvovirus in the emergency medicine literature. And obviously, this is an N of 1, so more study needs to be done to look at the safety and feasibility of the procedures done in different patients by different operators. Thank you.
Hi there, my name is Laura Oh. I'm from Emory University. So, in this time of unprecedented international conflict with our neighbors to the north, I think it's really important that we pause and reflect on all the good things that have come out of Canada. Stunning vistas, wonderful people, and most importantly, the 3M defib pads as a reusable alternative to commercial ultrasound gel article in resource limited settings. So when you perform POCUS in austere environments, it has some negative characteristics. It's really bulky, it's heavy, and it leaves a sticky residue. So previous researchers have looked into shampoo, hand sanitizer, and yes, even maple syrup. Canadian researcher looked into that as alternatives to commercial gel. But these gel alternatives, unfortunately, were only single use, and it wasn't clear if it was going to damage the probe to pour maple syrup on it. So now, the next innovation out of Canada is that they're using defib pads as reusable gel alternative with a pretty reasonable cost. It's only $7.50 each versus $2.50, bottle of gel. So this, I love it because a POCUS fellow did this project. So it is possible, POCUS fellows. So these ultrasound images were collected by a POCUS fellow in Ontario in 3 anatomic areas. He looked at PSL, hepatorenal interface, and mid-forearm ulnar nerve. And he trialed the commercial gel versus the 3M defib pads in a variety of scenarios. He was trying to mimic like using it in the wilderness. So I think he was imagining he was in a forest where he might get dirt on it. So he put the 3M defib pad in the dirt. Or he was imagining a wet condition. So he, put a probe cover over it. He also, threw it in the freezer to, check freeze thaw conditions. He air dried it, and then he used it post moisturizing of the air dried material. And then he sent these images to the CAEP EUS listserv, which just had a lot of sonophiles on it. Not necessarily everyone was POCUS trained or POCUS fellowship trained, but they all loved ultrasound. And he asked pretty basic questions like, does this lead to an interpretable image, yes or no? And by what he meant by that was, could it answer a very basic binary clinical question? Is there free fluid or not? Can you see the ulnar nerve, or not? Is there pericardial fusion or not? And he found that the 3M defib pads worked well in all conditions except when they were air dried, which makes sense. Once you've lost all the moisture in that pad, it's not going to work very well. But he was able to resuscitate those pads by pouring water on them afterwards. So the wet post air dry 3M defib pads performed very well. So the article impact is that you don't have to use maple syrup anymore. Defib pads are found to produce interpretable POCUS images across a wide range of environmental stressors, and this is a potential reusable gel alternative in a resource-limited setting. So future directions. So this was a single POCUS user and he's scanning a healthy volunteer. So does this work on non-healthy people when you're not fellowship trained? You will also want to explore the possibility of cleaning and disinfecting to allow storage and use with multiple patients to get the value out of that 750. And then these scans were generated using a cart-based system. So does this work well on handheld devices which may have a lower baseline image quality? So for me, this was a wave maker because in a world of AI, it's nice to see a low-tech solution that improves access to POCUS in low resource settings. Thank you.
Thank you all so much, and thank you all for joining us. Hopefully, this inspired your future directions in POCUS research. We do have a couple of minutes to open up to questions, either from the panel or I think we have a couple of the authors out here. If anybody has any questions about specific articles, please feel free to raise your hand. All right. You explained them very well. All right, thank you all again. And we'll see you at the AUS Mixer. Oh yeah, let's take one, yeah.